the area that I specialize in as a psychologist is called Dissociative Identity Disorder. It used to be known as multiple personality disorder, and sometimes people refer to it incorrectly as split personality disorder. When I mention this area of difficulty to people, often people have no idea what it actually is. So I always have to explain in quite a bit of detail what it is and how someone who suffers from this difficulty actually experiences it. So what is dissociative identity disorder? Well, dissociative identity disorder is where one individual has multiple individuals within them. They essentially have multiple personalities. And what really fascinates me about this disorder is how separate these personalities can actually be. These are individual personalities within the same individual, and they can be quite independent. And how they play out in an individual can really be very wide and varied, and this can differ from one sufferer of DID to the next, but also the different personalities within one individual can be very different in terms of the communication that they have with the main host, which would be my client, so the person who's actually presenting, wanting treatment, the person who has the responsibility for most of the day-to-day stuff. So when someone has DID, they will often have a lot of different personalities. So this might be up to 11, 12, maybe more personalities. And what we often find is that these personalities are all different ages and different genders even. And it's quite common for some of these personalities to even be children as well. So actually there is some young personalities within that individual who present themselves from time to time. Now, a person who's got DID might be able to communicate with some of these personalities within them, or but not all of them. And that might differ from time to time. So sometimes there might be a personality who chooses to host, and that personality comes out, and the main individual, the client, might be able to witness everything that's going on and be aware of everything that's going on, or else the individual might put things on private so that actually the main client can't actually witness what's going on. They go into a dissociative state, they come around and they're not actually aware of what's taking place, the conversations or the actions that have happened when they come around. And that can actually, it can be fine depending on who the other individuals are. So it can be really problematic if there is substance use, if there's self-harm, if there's some problematic behaviors going on. But actually, sometimes it can be completely fine when an identity comes out and is very respectful of all of the other identities in the individual. And the goal of treatment is not necessarily to integrate all of these personalities. And that's actually a common concern for people who come for treatment, who have DID. Sometimes their goal is very much not to integrate all of these personalities, that the preference of, and bearing in mind, the client's preference and the preference of the multiple personalities that they have, there might be a lot of different preferences. You really have to take each one of these personalities as individuals, almost as if you're doing family therapy, and really respect the wishes of each person. So if I'm working with a client with 12 personalities, I'll be very aware of each one as individuals and really respect each one of them and each one of their wishes when coming together for treatment, which is a very interesting way to do therapy. And I always find it very similar to family therapy, because you're just checking in with each individual, making sure that the work that you're doing is in line with everyone's goals and that you're being very respectful of everyone's wishes, which sounds very hard to coordinate and sounds very hard to get to know 12 individuals within one client, but it's actually really not that difficult, as long as you can really build trust and respect with these individuals, and that each one feels that actually they will gain something from treatment, and that you're getting everyone on board. And with this kind of treatment, I would say as a therapist, respect for these individuals is key, and respecting them all equally. So it's not just trying to work with your main client, you want to work with everyone. As I said before, it's like family therapy. If you were doing family therapy and you kind of favored one person over the other, it just wouldn't work very well. So each individual within the client is equal. They're all as important as the other. So the goal of treatment, as I said, is not necessarily integration. I mean, depending on if that's your client's goal, and that seems very consistent throughout the system, and all of the individuals have that goal, then that might be what you work on. But for a therapist to force the idea of integrating these personalities onto the client and forcing the client into doing some deep, heavy trauma work is not really the way to go. So how you would start treatment with a DID client is very much looking at their goals. What do they want to achieve? And as a therapist, my goal is always to just minimize risk and to maximize living in harmony, despite the fact that there's many individuals within the same person. So really, it's important not to place your own goals or your own beliefs onto the client, and apart from having the goal of just keeping your client safe and making sure that their life is fulfilling and as satisfying as possible. And as long as you can minimize risk for that client and do therapy in a way that makes sure that there is no self-harm or as little self-harm as possible, and other problematic behaviors such as substance misuse, alcohol misuse, anything that would cause the person harm, or where there's a catastrophic aftermath of that behavior, as long as you're minimizing all of that, then you can work on the system working very well together. You can definitely improve communication in the system. You can make sure that different individuals in the system are able to communicate with one another, and you can do that in all sorts of creative ways. Sometimes individuals have no access to, like, two individuals in the system have no access to communicate with one another. So what you might do is get one individual to write some notes to the other and get the other individual to respond. Or you might use videos. So particularly if you're working online as a therapist, you can get the client at the start of the session to video the session, so then other individuals from the system can actually watch the session back later, so they're aware of what's going on, they're aware of what other individuals have said. Now, sometimes when I'm working with clients, the individual will choose to put things on private, so that individual is sharing information with me that the main client or other individuals in the system might not be aware of. So how do you work with that? Well, really, I don't work in secrecy. If I'm working with DID where there's multiple individuals within the same person, I don't hold secrets. So anything that is disclosed to me, I make the client very aware that I'm not going to just be the bearer of secrets. But if something very heavy is shared, so perhaps someone, one of the identities shares some very traumatic information, and I think that my client is not quite ready to be aware of that information yet, I wouldn't necessarily disclose it, but I would say to the individual, I'm just going to make my client aware that we have had this conversation and that it's very heavy, and that we'll perhaps come back to it at another time. So then when things switch back to my main client, I would just explain to them that I've been given some information that's might be very difficult for them to deal with, and I don't really want to talk to them about it on this occasion in case it triggers them, but I just want to make them aware that we've had that conversation in private. Is that okay with them? And of course, if they really wanted the information, I would give it to them. So that's the way that I handle being given a lot of different information from different individuals within the same system, because bearing in mind, these individuals hold different memories, and the whole condition, DID, comes from trauma in childhood. So every individual who has DID has either experienced a very emotionally neglectful or emotionally abusive childhood, and there can be all different types of abuse. Some people would assume it has to be really horrific stuff. Of course, many individuals with DID do experience childhood sexual abuse or childhood violence. But for some individuals with this disorder, they will just have experienced emotional abuse or extreme neglect in childhood. The condition can also come from traumatic medical procedures, or it can come from experiences with war. So it doesn't have to be something that has been caused by the caregivers, but often it has been a case that people who develop DID have had really poor caregiving. And the reason why people go on to actually develop DID, it's a protective thing. So if someone is really little and they're experiencing something so horrific that they cannot deal with emotionally, that's where these alters start to develop, and the alter starts to deal with these heavy emotions so that the individual doesn't have to. And it always comes out of prolonged, very stressful experiences. And so these multiple alters switch in, they manage the very difficult emotional experience, and then it becomes quite an addictive thing. It becomes an automatic thing that actually later in life, this is how the individual learns to manage their emotions, and they end up switching very quickly on a day-to-day basis. And it's not necessarily always a bad thing. When people have DID, sometimes the responsibilities of everyday life can be shared out amongst other individuals within the system. So some of the alters can have great strengths and talents that the other alters don't have. And when a system works well, they can actually work very collaboratively, just like a family, where they share tasks out and they communicate and they help each other out. And often alters can switch in and out very smoothly so that individuals that might be in the very same room don't even know that a different alter is present. And sometimes alters don't even mention that they've switched because it becomes complicated. So sometimes communication is quite good in the system. Sometimes two alters work very well together. In fact, sometimes two alters actually are the main hosts, and you might be working with actually two main clients essentially. So two individuals, two identities that keep switching in and out, but they work very well in harmony, and they might have very complementary traits. So one person might be very assertive and very good at speaking outright, and the other personality might have strengths in other ways, and this can work really well. It doesn't have to be all chaos in this system. That people with DID can have a lot of satisfaction in their life. They can have very positive relationships in their life, very positive friendships. It's not all chaos and dysfunction, but it's like any disorder, the severity there's a whole spectrum in terms of how severe someone might actually be. And the treatment for DID, there's no set treatment. So you're not necessarily going to be going straight in and saying, oh, if I just address the trauma that you've experienced in childhood, you'll be fine. In fact, some people with DID may never need or want or be ready to address the trauma. That might not be the most helpful way to go. For other people, their treatment might very much be about addressing the trauma in order to help them in the here and now. Treatment can consist of many different things. It can consist of cognitive behavioural therapy. It can consist of psychodynamic therapy, eye movement desensitization, reprocessing, DBT, which really helps people regulate their emotions. And you really want to tailor that treatment around your client's needs. You can do a lot on the behavioural side of things to really minimize problematic behaviours. You can work on assertiveness, communication skills. You can help them with their relationship. Their partner or family members can join the therapy so that you are all communicating to create a very supportive framework for them, so that when difficulties happen in their life, such as perhaps a manic episode or whatever difficulties come up, then their loved ones around them really know how best to support them. DID is really a fascinating condition. It's really interesting to work with, and no individual with DID is the same. That really, when you work with one client with DID and you work with another client, they might be very different in terms of the problems they come with and the presentation. And diagnosing DID, if you really want to get an official diagnosis, it's a 3-hour assessment. It takes quite a lot of time to get that official diagnosis, where you can write a report for your client and give them a report that they can take to professionals to show them this is a real thing. Because actually there's a lot of doubt about this condition. A lot of people don't believe that it exists, and really it does. I mean, this is a very real condition. People are not making it up. They're not pretending to have all of these other identities within them. But it's not uncommon for professionals, such as medical professionals or some psychiatrists, some therapists even, to doubt that this actually really is a thing. And this is quite difficult for individuals, because when they're trying to explain that they've got DID, well, first of all, members of the public don't really know anything about it. It's rare for people to have a lot of information about DID, so it's kind of hard to bring it up and try and explain it compared to other disorders. Like if you just have anxiety or depression, people know a lot about that. People tend to be very understanding. You don't have to explain it from square one. But with DID, you really have to start with the basics and try and understand and try and really explain to people what it is and what it's like for you. And often it's met with a lot of doubt, a lot of surprise, a lot of confusion. So really people with DID, quite rightly so, are often very careful about who they disclose it to. And they often wait until they've really built up great rapport with someone and they feel that that person is someone to be trusted, that that's a supportive individual and someone who actually will take the time to listen and be very curious and interested in what the condition is and what it involves. And of course, people with DID can explain it to people, but it's understandable why they might have reservations in trying to explain it to everyone. And then often they will have had a history of doubt or confusion, and that might even be medical professionals who've doubted them. So actually having a diagnosis, a report that says they really do have this condition can often be very helpful. But when working with someone who's got DID, you don't necessarily have to do the official 3-hour screening process. It's a very lengthy process. It's not necessary to do that because if you're a practitioner who's skilled enough at treating DID, you can actually diagnose it with clinical interview and with spending enough time assessing the client. You can give them an unofficial diagnosis and you can come to an agreement that they most likely have DID based on the fact they're presenting with multiple personalities that you as a practitioner are witnessing and seeing. Because when those personalities come out, it's very real and you can tell these are very different individuals. It's not the person just acting, making it up or putting on the fact that they've got other personalities within them. The different alters within a person with DID can form at different points in their life. Some of the alters might have existed for a really long time, and new alters can appear at any point. Also, alters can integrate into one another. So 2 alters might actually merge into one because there might not really be a need for them to be 2 alters anymore. And often alters emerge and disappear based on what the person is experiencing in their life, what kind of needs they have, what kind of things they need help with in terms of managing certain types of situations or emotions. And really a person with DID can evolve and change and have lots of different fluctuations and changes with their alters across the course of their life. But we're never trying to get rid of any of these alters or give them the impression that they're not welcome. I have as much respect for individuals' alters as I do for the individual main client. So why do different alters differ so much? Why do certain alters prefer different things compared to others? Why does one alter have a great interest in art, but another alter has a great love of science? Why is one alter really aggressive, but the other alter is a really kind, caring, empathic individual? Well, we don't really know the answers to these questions apart from the alters help with whatever is needed. Because if we think about where these alters have emerged from in the first place, the alters come out of great distress and trying to cope with traumatic experiences. So therefore, some of the alters' strengths will emerge from what they've had to face with, what they've had to deal with and go through. And I find it really interesting that often there's different genders when someone has DID. So some of the alters are male, some of them are female, and perhaps that might be because when individual is experiencing something particularly difficult, if they're a female client, they might feel that actually a male might deal better with this type of situation. Of course, this is happening on a very subconscious level. It is not conscious choice that the client is making when these alters are emerging. The alters just occur, they take shape, they develop as individual personalities in the exact same way as we develop as individuals and develop our own personalities. The alters' personalities evolve, shape, emerge in a very similar way. There is no reason why alters have particular interests or particular personality traits apart from the experiences that they've been through, the experiences they've had within the main host body is what helps shape them. The advice I'd give to other therapists who have perhaps their first client with DID or a number of clients with DID is to never force your client to integrate. Don't give them the idea that if they were just one person they would be better, because that is truly not the case. DID is a very protective thing. People function very well because they have DID. In fact, if someone has all these traumatic experiences and they don't have DID, often they're experiencing a lot more difficulties in terms of emotional challenges and lots of kind of experiences they have to go through because they're going through all of that trauma, and they're an individual with all of this trauma without getting to split into other alters that can help out. So really my message for therapists is don't impose wishes of trying to get these alters integrated. Really investigate what your client's preference is and what their goal is. And also don't force your client into working on the trauma stuff. It might not be relevant for them to do so. It might not be helpful for them to do so. And particularly therapists who have a great wealth and depth of experience of treating trauma might feel that that's where their skills lie, and therefore they might be very much encouraging the client to go there straight away or very quickly with the trauma treatment. But actually you might never do the trauma treatment as part of treating a DID client because it might not be helpful for them. It might be very triggering, overwhelming, it might create a lot of setbacks, and it might not be part of their objective. Their objective might be that they want to work on a difficulty in their life in the here and now, and that actually taking them back to the past and getting them to address all this trauma might not be in line with actually helping them achieve what they would like to achieve. A lot of different things can trigger someone to switch to another alter. This might happen many times a day, and it really depends on the individual. Some individuals might stay present for a lot longer, and of course it really depends on what's happening in the person's life. Perhaps if they're under a lot of stress, they might find it much easier to switch, or they might find it more difficult. It depends on what's happening with the different alters. Some alters might not step in so willingly if they're under a lot of pressure or stress. Sometimes alters will step in too much, and they will force host, and they won't allow the individual back being present when they want to. Some alters can be a bit sinister. Some alters can feign being the client when actually they're an alter. And all sorts of interesting things can happen with the alters. Sometimes there's harmony with all the alters, and they're all really considerate of one another, and sometimes there's chaos. Sometimes there's maybe one alter that's just causing a lot of problems, and then you have to try and address that, and maybe try and, as a therapist, talk to that alter and see what's going on with them, and see if you can kind of help them become more at ease, and help them work through any difficulties they have that might be leading them to carry out the problematic behaviour, such as excessive drinking or self-harm or eating disorders or whatever might be going on for them. But it's really about communicating clearly with all of the alters, finding out what everyone wants, having complete respect for everyone's wishes, everyone's therapeutic goals. And bear in mind, some of the alters may not want to come to therapy at all. And it might be fine if they just choose to kind of stay out of the therapeutic process without causing any problems. But some alters might be very much against having therapy, and that might be difficult in the therapeutic relationship. Memory is a very interesting thing with people with DID. So some alters have co-consciousness, so they all hold very similar memories, but some of those might share some of the memories and not share some of the other memories. Some alters will almost always be co-conscious and always kind of holding a lot of the same memories, experiences. And then there might be other alters that are very separate, that remember some things that the other alters have no awareness of, and the main host, the main client has no awareness of. So memory can be all sorts, it can work in a very interesting and very complex way with these individuals. Also, when they front, some of the alters might always front in private, so that if an alter is talking to me, then my main client will never have any knowledge or recollection of what conversation has taken place. So new memories that are being formed are not always memories that the client is going to be aware of. So memory is it's a confusing thing for someone with DID. Of course, there's ways around this, and there's ways to make it easier, and things like using notes or taking videos, particularly taking videos of the therapy session, can be very helpful in letting the DID client in on extra information so that they can really enhance communication between the different alters. And that's definitely something in therapy that becomes very helpful to do, is actually enhancing communication across the system. Very similar to if you were doing family therapy, the more communication that's taking place, the better. And the more communication that's taking place, the better that is for enhancing memory. Of course, for the main client, it might not be helpful for them to ever gain access to the traumatic memories from their childhood. Perhaps that might be too difficult for them, too painful, and not actually helpful. Because remember, these alters have been created for a reason. These alters have been created to help handle extremely difficult traumatic experiences that were taking place in that young person's life. And those alters often stick around because they will hold on to those memories and deal with a lot of emotions that might be similar to the emotions that were brought about when those traumatic incidents took place. So memory doesn't always have to be really consistent across the system, and you don't have to try to help your client regain all of these lost memories or memories that they don't have. But of course, if your client is coming around in difficult places where they wake up intoxicated, they don't know how they got there, and there's a lot of missing information, then that's problems in the system. That's where, just like if you're doing family therapy with a teenager who's going out and getting drunk, you need to kind of address that behavior in family therapy. You would also address that behavior with a DID client, so that the alter that's going out and getting drunk is actually improving on their behavior so that the system can work better together. And it's the same with memories, that if there's problems with the dissociation and the missing memories and missing time, you can work with the whole system, all of the alters in your individual client, to help improve on the missing bits of information so that it's not causing them as much distress. If you've got any comments about this condition, if you're a client who might be experiencing this condition, or if you're a practitioner who's got a question about a client that you have who has this condition, feel free to leave a comment below. And if you're enjoying these videos, don't forget to subscribe to my channel.